Hi, my name is Jared Marks, and I'm a professor of emergency medicine at the University of Nebraska Medical Center, where I've been an ultrasound director for quite some time. Been teaching ultrasound for over 15 years and am excited about the opportunity to talk to you today about ultrasound and fluid responsiveness. I feel like this is the great white well that we've been trying to find in medicine for quite some time of how to non-invasively check for fluid responsiveness in our most critically ill and hypotensive patients in sepsis, septic shock, or just shock for any reason. And what we're essentially trying to do, we've all seen this, the Starling curve, and what we want to do is determine if we give more preload as we move to the right on this graph, are we really going to increase stroke volume enough that it's for each, subsequent bolus of fluid, are we going to continue to increase the stroke volume and support their blood pressure? Or have we plateaued and we're in this region where we can no longer give fluids because it's not going to be a positive impact? And so we really want to determine this. And ultrasound's been presented as one way to do this. And there are some good utility, and this has been changing and growing and evolving, and it will continue to do so. What I want you to do is keep in mind what I'm going to teach you today needs to be taken in context. These are single data points, and they need to be taken in correlation with everything else. I don't think that any one measurement should guide us, that we need to take this in conjunction with everything that's going on with our patient. So what do we mean by fluid responsiveness? What we mean is if we give IV fluids and then we increase the preload, will that increase the stroke volume and further support the blood pressure or increase the blood pressure? And if it is, then we want to keep going with IV fluids. What we want to look at is if we increase the preload, but somehow, for some reason, whatever it may be, that the heart can't handle it, that we don't throw the patient into pulmonary edema or have other organ congestion secondary to us giving fluids when it's not going to be beneficial. Now, when we do ultrasound to determine if a patient is fluid responsive, we need to do a full cardiac ultrasound. Now, I'm not talking about echocardiography. That's not us, right? If we're doing point-of-care ultrasound, we're doing this at the bedside, trying to determine what interventions our patient needs. But with that said, we don't just do one view and stop. We need to look at all views of the heart, take all that information, and correlate it together to best determine what our patient needs. Now, this includes our parasternal views, our apical, our subxiphoid, and IVC views. And when we do a cardiac ultrasound or any point-of-care ultrasound, we need to have very focused goals. These are the binary questions or the yes-no questions that help us determine what's going on for our patients when we do cardiac ultrasound. This is getting a little blurred with the more capability we have with our machines nowadays, with artificial intelligence, and some of the stuff we're going to go through today, quite honestly. But these things, taken in conjunction with what we see with the patient, often we can figure out whether they will respond to fluids or not. And we'll talk a little bit about that here for a moment. So first thing I want to worry about is, are any of the chambers of the heart not normal size? Are they large? And what we have to do, we can do this with what we call the rule of thirds by just visual observation. We don't need to do any large in-depth measurements. And the rule of thirds require essentially three views that are part of those main views I showed you before. And the first being the rule of thirds that's well described in the parasternal long axis. And what we're going to do is look at the right ventricular outflow tract, aortic root, and left atrium. And essentially, between this spot up here and this spot, do each of them take up a third of the screen, or are they all equal in size? Now, if any one looks larger than the other, we would consider that visually larger and report it as such. Now, obviously, that doesn't answer the reason why it is enlarged, but it can give us an idea. Now, keep in mind a left atria that is enlarged, that might be mild mitral insufficiency, or that may be horrible mitral insufficiency. And so we've got to take it with a grain of salt. We've got to watch everything else going on the ultrasound, but this will help us at least know, is a chamber big? Now, I would caution you, if the right ventricle is ever big, I'm not as worried about fluid responsiveness as I am figuring out why that is and how to fix that. The aortic root being the same thing. Now, that's the first rule of thirds. The other rule of thirds is that the left ventricle and the right ventricle ratio should be 0.6 for the right ventricle to the left ventricle of 1, or 60% that size. This is the second rule of thirds, and this tells us if the right ventricles are big. And again, if the right ventricle's big, I'm taking pause and getting away from, is this fluid responsive to what do I need to do, or what interventions or what pathologies could be present that are causing the right ventricle to be this way. One that I go by, it's not well described in the literature, but the volume of the atria compared to the ventricle is about a third the size. So I look visually to see, is the size about a third of the left ventricle? And if it is, then great. If it's enlarged, I'm looking at, well, what's going on? What's going on with those valves? And just kind of putting that in context. Now, keep in mind, any enlarged chamber indicates to us that there may be other pathology, and we need to maybe change our frame of mind away from, is this fluid responsive, to how do I change or treat that pathology that's causing this? An enlarged chamber of the heart, again, is going to indicate other pathology, and we need to take it with a grain, or maybe get away from just thinking, is this fluid responsive, and start thinking about the other pathologies. But what can we do to improve their pressure support in the meantime based off of some of those findings? Now, we also have to be able to estimate the function of the heart. And we're going to do this. We're going to go over how we estimate the function of the left ventricle and the right ventricle to determine how they're playing into this. So when we look at any chamber of the heart, we have to be able to see the inner myocardial wall in order to estimate the ejection fraction. We are not estimating the movement of the chamber, including all the muscle. We're estimating the change in the volume of the ventricle or the chamber between these walls here and here. And on a parasternal lung, we're going to be watching for these walls to move inwards towards each other, and we're going to see an example of this. So on the left, we have normal, and on the right, we can see a severely reduced function. So we can look at those inner chamber walls and see there's a significant difference in their function. So the one on the right, we're going to have caution about giving them fluids, right? And the one on the left, we can probably give them fluids and they'll probably be okay. Now we need to take that in correlation with everything else. You're going to hear me say that over and over again. When we look at the parasternal short axis, so we've rotated the probe towards the patient's left shoulder or left midclavicular line. We're going to look at the inner chamber, and then we have this donut shape. And what we want to do is see how that center of that donut is closing down towards each other. And here we'll see again, normal on the left and abnormal on the right. So severely reduced on the right. We see some other pathologies. There's some thinning of the ventricular wall. There's a pacer wire in here, but this is telling us that we've got to be cautious of, whereas on the left, again, we can probably most likely give this person fluids and they'll probably respond to it, depending on what else we see. In the apical view, we're going to look at the left ventricle to shorten, and that can be the base coming towards the apex or the apex coming in, and then these walls closing into each other. On the right ventricle, most of our contraction or ejection fraction is going to happen along the longitudinal plane. It's about 70% or 2/3, somewhere in there. And then we get some of the movement into the free wall and towards the septum. And keep in mind that loss of one of those can affect the function of the right ventricle. And so when we look at this again, we're going to look at both chambers. We can see nice normal function. Look how that shortens in the right ventricle on the left. We can also see the mitral valve moving up. We can see that nice function on the apical view, normal. And then on the right, the heart's so big, there's so much cardiomegaly that we are struggling to get to the apex. Now keep in mind, this is a papillary muscle, so the myocardial wall is clear out here. And we have to see how much movement that has in, and it doesn't have much. And if we look at this area, it's not shortening up. This isn't moving in. We don't really see the apex coming down at all. Whereas on the contrary, on the other side, we see that moving well. The right ventricle is so big, we don't even see it completely in here, and so that can be difficult to estimate its function as well. In the subxiphoid view, we're going to also be looking for the same thing. Again, we're going to have some shortening along this way. In this view, it's just a little easier to see this move in, so that's why I've drawn it this way. But again, we're going to look at the inner myocardial wall in the left ventricle and see how much it closes down. Again, we're going to have normal on the left, abnormal on the right. We can also see on this one on the right, look how big those atria are, right? Those are very dilated. That's telling us that there's some significant heart failure going on. There's probably some valvular insufficiencies between the chambers. So we want to be cautious anytime a chamber's big about giving fluid and fix the underlying issue. You can get a subxiphoid short axis. I really like this view. I don't think it's traditionally taught. I didn't teach it for a long time. In emergency medicine, a lot of people doing POCUS, we'll rotate the probe marker towards the feet. If you follow the cardiology convention, you'll rotate the probe marker towards the head. And this will just be a flip view, but we want to get the left ventricle, again, looking like a donut. We'll fan over to their left. And we're going to, again, just like the other, look and see how much that chamber is closing down. And we can see that great function on the left again, and on the right, severely reduced function. Finally, so we have an idea of what the function of the heart is, and then we can consider what is the volume status, or what's the central venous pressure. For the longest time, we thought CVP correlated with fluid responsiveness, and it doesn't. It does tell us the pressure of the right heart, which can be up for multiple reasons. That can be fluid overload. It can be right heart failure. So we want to look at this, and what we're going to be doing is looking at the collapsibility of this, or even a collapsibility index, but we can just visually do this. And we're going to do about 1 centimeter past the hepatic vein, or 2 centimeters past the hiatus of the diaphragm here. And what we'll see, this has some variation, has probably around 50%. They're not breathing hard, so this is just a normal IVC, normal, comfortable patient. If we had them sniff, we could probably see it move more. Keep in mind, a ventilated patient's going to, as they get air forced in, will dilate. Compared to a spontaneously breathing patient, it will collapse when they get air in. So you're going to have opposite movement, but the data is still pretty good for both to give us an idea of the central venous pressure. And when we look at this, we got to remember that it's got to be open. Otherwise, we're going to be in total collapse. Now, we don't expect everybody to be of the same size, but we want to see them at least dilated about 1.5 centimeters, and then what variation has. If they're collapsed and there's no variation, it's because they're totally collapsed, and you need to put them in this low pressure. Now, why does this matter? Because if we take the collapsibility index, or that central venous pressure, and we correlate that with their ejection fraction, there's probably a good, good feeling, or a good knowledge that we're going to have this type of response. So if they're hyperdynamic and collapse, they're likely going to respond to fluids. Whereas if there is no collapse and they're severely reduced, they're probably fluid overloaded. So, if they're in shock, we need to consider where they fall in this diagram, and what that means. This is how I think of it in my head. And clearly there's some gray areas. But, if you can take a screenshot of this, this may help you as far as correlating those two things together. So one item that we can use ultrasound to assess it when determining fluid responsiveness is lung ultrasound. Now, lung ultrasound itself will not predict fluid responsiveness, but it can be a way of monitoring if we can get fluids or when we should stop. And so I want to talk about that briefly here for a moment. I often use this in conjunction with cardiac ultrasound in my critical patients, and so I'm already doing this, and it gives me an idea of how to move forward with them. In order to do this, what I'm going to say to start with is we don't want to give fluids when there's significant pulmonary edema, and especially if that's cardiogenic. If they have a reduced EF, we are severely reduced EF, and they have this, we shouldn't be doing it. Now, some people may respond even with a reduced EF. But we need to reflect back on, why does pulmonary edema develop, or other edema in the body? And that's because blood vessels leak. And the reasons they leak are threefold. First, we have hydrostatic pressure, just simply that the pressure inside the vessels is higher than the pressure on the outside of the vessels, and that therefore lets fluid leak from inside the vessel to out. Additionally, we have oncotic pressure, where in low protein states, the fluid inside, or the protein inside the vessel, is lower, and therefore it creates a gradient, and the fluid will leak out to equilibrate that concentration, and is one of the reasons we lose fluid from the vessel. And finally, this especially happens when we have inflammation or injury, and we have increased permeability of the vessel. This is in order for the body to fight infection or to get inflammatory cells into the area to heal. And so all three of these are reasons that we have or fluid leak out of the vessel into the interstitial space. Now, when we have diffuse pulmonary edema or significant fluid in the lungs, we cannot give fluid. We've got to be really cautious about that, because that can make our patient decompensate more. And because that heart and lungs are just so tied into each other, and we need to be cautious about this. Now, one area that we don't know for sure, and you won't know for each patient, is if they have focal edema. Now, focal edema is most often infection. There's going to be a pneumonia, a consolidation. And we don't know if we give fluids in these sometimes, if it's going to make them blossom that pneumonia or have increased fluid into the interstitial space. And so we've got to be cautious here. I can't tell you one way or the other whether you should give fluids here. It might be that you try it or you do it in conjunction with the cardiac exam that we just talked about. And then from there, you determine how they're responding clinically. What I will say is if you do a lung ultrasound and they are fluid-filled lungs, that there are B lines everywhere, you should not give fluids to these individuals. And this is what it's going to look like. You will have B lines, as we see in the ultrasound, or these bright lines that start at the pleural line right here and go down from there all the way and increase in intensity all the way to the far field. And you'll have those throughout the lung. It's not just in one spot, but it's throughout the lungs. Those patients you shouldn't be giving fluid to. However, if we have a patient that has clear lungs, no B lines, as we see here with the pleural, the lung sliding or pleural sliding here, and no B lines, that's probably somebody we could try fluids and watch and see what happens. Now, we can always give fluids, assess, see what's happening with the blood pressure, see what's happening with the heart rate. But we can also introduce ultrasound, which may be a little earlier in detecting pulmonary edema developing secondary to our fluids. And this would be typically at the lung bases or thought to be, but we can include doing a lung ultrasound as fluid resuscitation occurs to see if pulmonary edema is developing. Now, again, I'm going to state this over and for lung ultrasound. We are not predicting fluid responsiveness. What we are doing is using lung ultrasound to monitor when third spacing is developing, and that specifically being in the lungs, and that can be detrimental. So we want to catch it early. This is better than a physical exam because it is objective. We can see it, assess it. And so we can use lung ultrasound to determine what effects the fluids are having on the lungs. And if they're still clear and they're improving, we can continue with fluids. So a more advanced scale that we can do and has good literature to support it is predicting the cardiac output and using that calculation after intervention to see if the patient is fluid responsive. So this is not an easy thing to do. Can be hard in our critical patients, but has some good data behind it. And we're going to go through that right now. So in order to do that, we got to remember that cardiac output is not only stroke volume, which we're going to measure, but it's also the heart rate. So we do have to pay attention to both of these, even though the literature mostly looks at what's called a velocity time integral, or VTI, which helps us calculate the stroke volume. We have to keep both of them in mind, in my opinion. And this is just a reminder that those two correlate. There's different things that affect the stroke volume. There's different things that affect the heart rate. And both of them together can affect what the overall cardiac output is. Now, in order to measure or calculate a cardiac output, we need to go through a few steps. So on our cardiac exam, when we obtain the original parasternal long axis view, we can do this measurement in the case that we want to measure this at a later time, but you will have to interact with the calculation package on your machine, and is a little bit more difficult than just the basic exam. So what we're going to do is we're going to look at this area here, right below the valves of the aortic, the valves of the aorta, and this is our left ventricular outflow tract diameter. This diameter is going to be used to go for the radius, and this radius will go into this formula. So the formula is just the area of a circle, and what we're going to imagine is that we have a lot of circles or discs stacked on top of each other, and we're going to measure how far they get moved out, how many of them essentially, in a sense, make it out. And by getting the height of those discs pushed out, we can get the volume of a cylinder, and that gives us our stroke volume. Now, so that's our first step. We're going to measure that left ventricular outflow tract. Our second step is we've got to use Doppler. We can use color Doppler to help us assist in placing the gate, but we're going to use pulse wave Doppler. And what we have to remember is in a parasternal long axis, we would get an image like this, and we would not get great measurements of blood flow. So we have to actually get in this position. We have to get blood flow moving towards or away from the probe. And in this case, we're going to get it moving away as blood tracks from the left ventricle through the left ventricular outflow tract and up the aorta, which is not seen here. So again, that diameter is right here. We cannot measure it in this view. We have to measure it in the parasternal long, but then we can measure the height of this cylinder. And how we're going to do that is we're going to place a Doppler gate right here. We are not going to use any correction of the angle of blood flow. We're just going to put the Doppler gate right here. Ideally, as the heart's moving up and down, that valve's opening and closing, that when the valve closes, it's ideally right over your Doppler gate. This is drawn just a little above for demonstration purposes, but that's what we'd ideally want. So you're going to hit your Doppler a second time, and this is pulse wave Doppler again, and we're going to get a tracing that looks something like this. And you may have to adjust your baseline, you may have to adjust your scale, but eventually, after we get those things adjusted, we're going to have a tracing here. You'll hit freeze on your machine, and you're going to measure the height of this upside down triangle, and this is the height needed to calculate the stroke volume. So we need to do the entire thing, not just a peak velocity, but we're going to measure that entire thing to calculate the stroke volume. And we're going to use our machine to do this. This is going to be our velocity time integral, but this is going to be our pre-intervention calculation. And so we can then intervene. We're going to remember or record this, and that's going to give us, if we enter our heart rate, we'll get our cardiac output, and we'll also have our VTI that we can use for a later calculation. We have to intervene, and we have to test to see if they're fluid responsive. We can do this one of two ways. You can give them fluids. I would recommend you give a 500 milliliter bolus, or you can do a straight leg raise. Straight leg raise is great because you can do it right immediately in the room, see if that increases their cardiac output. The difficulty with a straight leg raise or even either one of these is if you can still get the apical 5 chamber, which may be a little bit difficult in just a supine position. But it is possible, and you can try it. Now, here's a problem. This is a mistake I see made. You have to reset your machine. And what I mean is you can't just continue adding measurements of your VTI because it's going to give you a measurement, but it's going to start averaging them over time. So if you have a bunch of different waves, and to that credit, if you have a bunch of different waves before that are varying sizes, you should measure several of them to get an average. Then you need to reset your machine. And I would say you end your prior exam and you start a new one. The only issue is it's going to want to calculate a cardiac output, and you're going to either have to measure again your left ventricular outflow tract. I don't like that as much, but you can. Just make sure it's the same measurement. Or I just trick my machine. I save a still image and create the same measurement there. And then I go right back straight to getting the VTI post. And so I'm going to, again, get that 5-chamber view. We're going to measure that again, and we're going to have a post-treatment velocity time integral. We can then take our pre and post and put them into a little formula here. So we can subtract the pre from the post and divide that by the pre, and then times that by 100%, and that will give us a percent change. I want you to keep in mind that, again, this is where I have a little consternation with this, is that your cardiac output is what we're concerned about, and we can increase the stroke volume. The heart rate may change and may increase our cardiac output, but we should still consider that. But the data is being measured off of our VTI, so we can use that calculation. What we find is that if we have a change of greater than 15%, that we have a very good sensitivity that they are going to be fluid responsive. And if, however, it's 10 to 14, it's a little bit less clear. They may or may not be. And then if they're below 10, they're absolutely not fluid responsive, and you need to look at other interventions to improve their pressure. Now, this method of measuring the VTI and the cardiac output, I mentioned you can do it. You do a pre and a post. You can do this over and over again. So as you fluid resuscitate, if they are fluid responsive, you can then measure them again after another bolus. And each time that you measure, as long as they have this change of greater than 15%, you should keep going with fluids and they should be fluid responsive. Just keep in mind, though, as you do these repeat examinations, that once they are less than 10, you need to stop. Well, I hope that is educational for you. Measuring or predicting fluid responsiveness is that great white well. It's not always easy. There's a couple things we can do to have a better idea if they'll be fluid responsive. Just remember, these are all data points, and we can't just treat based off of these, and we need to take the whole clinical picture into context.